This is the Cardio Ohio podcast, a presentation of the Ohio chapter of the American College of Cardiology. This is Kenny Graywall, president of the Ohio chapter and host for today's discussion. Further information about this podcast, including speaker biographies as well as references, are available at ohioacc.org, where you can also provide feedback and suggestions for future topics. The podcast will also be available for download wherever you access podcasts, and we encourage you to subscribe to receive updates on future sessions. I'd like to welcome everyone to our fourth episode of the Cardio Ohio podcast. Today, we'd like to have a special episode to recap what I thought was an excellent meeting that was just held in the last few weeks, the 2022 Spring Summit for our Ohio chapter. This was a half-day meeting, and it really covered an extreme variety of topics, all of which were very timely and all of which were very clinically focused. So I'm really happy to have three members of our planning team for that meeting joining me today to recap just some of the really key teaching points and practical points from a few of the talks. I'd just like to introduce our panel. First, from here in Columbus, we have Andrea Robinson. She's currently the CV team committee chair for the Ohio chapter. She's also a practicing nurse practitioner here at Ohio Health with a focus on electrophysiology. Andrea, welcome.
Thank you, Dr. Graywall.
I'd also like to welcome from Cleveland, Ben Allenshire. Ben is a final year fellow at the Cleveland Clinic. He was part of the planning team and one of the presenters at our Spring Summit. And he also will be continuing, I believe, his training at the Cleveland Clinic in cardiac imaging. Correct me if I'm wrong, Ben, and welcome.
Dr. Graywall, you're correct. And thank you. I'm excited to join.
You'll be hearing more about Ben as well in some of our future episodes, as he is going to continue to be involved in some of our future podcasts. And then finally, last but certainly not least, from Akron, I'd like to welcome Joe Petrolongo. He's a current trustee on the board of trustees for our Ohio chapter. He's been involved in the chapter and contributed in numerous ways over the years. He's an invasive non-interventional and vascular specialist at SUMA in Akron. Joe, welcome.
I'm Kenny. Thanks for having me.
Yeah, appreciate all three of you joining me. Andrea, I thought we would start with you. What I thought was one of the excellent talks at the Spring Summit was by Dr. Christopher Ellis, and he was discussing closure devices for left atrial appendage. Dr. Ellis emphasized several things in his talk. First of all, I just thought I'd ask you, since you're a clinical practitioner in EP and see a lot of these patients with AFib, why do you think there's such a need for these devices now, and why do you think their role is growing as a treatment option for patients with atrial fibrillation?
Well, I think certainly as the number of options for patients grow, it just increases our ability to treat them appropriately. I'll kind of go through some of Dr. Ellis's points, but there's a lot of niche cases out there that, prior to the approval of some of these surgical devices and as well as the epicardial devices, there really just wasn't anything. And so a lot of patients would just go either untreated and at risk for stroke, or they'd press on with anticoagulation and have risk for bleeding. So the game has really changed over the last decade. And I think Dr. Ellis did a great job kind of going through some of those updates.
So we've been using the Watchman device for several years. I think most of us are comfortable referring patients for that device and seeing good success. What were some of the things he outlined in terms of the need for additional devices or ongoing challenges with this class of devices?
Sure. So he started out by showing a couple of case studies. The first two were both patients that had persistent left atrial appendage thrombus. One was in a setting of severe LV dysfunction, which was then treated with a CRT device with an AV junction. With improvement of LV function, the LAA thrombus resolved, but then unfortunately she had a mechanical fall and eventually succumbed to complications from intracranial hemorrhage. The second patient had persistent LAA thrombus, and this was even despite systemic anticoagulation with a DOAC. So with that, he transitioned to review some of the data for epicardial LAA closure, which I think some people are a little bit less familiar with. In 2021, LAOS 3 was published, which is actually the largest left atrial appendage closure trial there is. And this was comparing surgical closure with no surgical closure in patients undergoing cardiac surgery and had a 5-year follow-up, and did show 37% reduction in all strokes when the LAA was included. Dr. Ellis reminded us to keep in mind that this is sort of a belt and suspenders approach for patients in this trial, because they did continue on anticoagulation, and this was secondary. There really was no formal regimen to do follow-up confirmation imaging to confirm closure to allow safe discontinuation of anticoagulation. But the benefit was, this did show really good successful closure rate. This was using the AtriClip device, about 95%. He also went through and reviewed some of the data on Lariat. This is another epicardial closure device that is considered non-surgical or minimally invasive and is done with either an electrophysiologist or an interventional cardiologist. Some of the data on this isn't quite as robust for the closure rate. It does show success between around 60 to 70%, which is not as successful as AtriClip, but he did point out that when it is 100% included, it does have a similar observed stroke rate, which is quite low. His really big takeaway from those epicardial devices is that these are really appropriate for patients who have refractory LAA thrombus despite anticoagulation, possibly have risk factors for putting an endocardial device in, or patients with prior intracranial hemorrhage that you really want to eliminate the need for any antithrombotic therapy at all.
Joe, in your clinical practice there in Akron, are you seeing the AtriClip being used on a more routine basis with patients who are already undergone open heart surgery? Because I think that's certainly been what we've seen here in Columbus.
Yeah, actually, Ken, we are. It's starting to creep into the standard of care here slowly but surely. And in fact, there was a case we were discussing recently in one of our valve conferences, and the surgeon was talking about what his plan was, and it certainly included in a patient without atrial fibrillation and no mitral valve disease to put a left atrial closure device in.
So Andrea, I know he also talked a little bit about advances and new options for interventionally placed devices as well.
Yeah, he did. So I think most everyone is pretty familiar with the data on Watchman, even up to the 2.5 generation. So, I won't review any of that data, but he did review Pinnacle Flex, and this is with the newest generation updated design of Watchman that's now commercially available. Pinnacle Flex demonstrated even improved safety from Protect and Prevail with 0 device embolizations, 0 pericardial effusions that required drainage, and a 0.5% major complication rate. And the efficacy was also great as well, with near 100% implant rate. In follow-up, nearly 90% of patients did have no detectable flow. So really, really great continued safety and efficacy with Pinnacle Flex. He also reviewed Amulet. This is the newest commercially available endocardial device, and it's a little bit different design. It's a disc and hub device. This is placed in a more proximal position than Watchman. And in that IDE trial, it compared head-to-head with Watchman. What he pointed out that he thought was most notable is PDL, or paired device leak, was seen in less patients receiving Amulet than with Watchman. Implant success remained high in Amulet. Safety favored Watchman by a small amount, and it did demonstrate shorter procedural time. He relates this as likely to the operator experience curve with Watchman. Some of the secondary endpoints for DRT slightly favored Amulet, and intracranial hemorrhage data slightly favored Watchman. But another benefit is that Amulet labeling does not obligate the patient to anticoagulation, and you are able just to use dual antiplatelet therapy immediately following implant. He also pointed out there are some unique left atrial appendage anatomy which favors Amulet as well. So really his key takeaways regarding the endocardial left atrial appendage closure devices is that if a patient has typical LAA anatomy and the focus is on getting your patient through a procedure quickly and safely with a high chance of success, Watchman Flex would be your device of choice. Downside is you can still see some peri-device leak. some of which in seen in follow-up can increase over time and does still carry about a 2.5% chance of device-related thrombus. And then the FDA labeling still does require anticoagulation for 6 weeks post-implant. The takeaway for Amulet is that, if you really are focused on wanting to place a device with no true peri-device leak, and you may be able to use some more challenging anatomies, and if you want to avoid use of anticoagulation, then Amulet's your device of choice. He did also point out, though, in about 80% of patients, it really is toss of a coin. Both Amulet or Watchman Flex would be appropriate for the majority of patients. So I think my overall takeaway from the entire talk is it's great to have options. So I guess this kind of brings up a question to me, is that, as I'll put it out to the group, as a referring cardiologist, are you guys now referring for a specific device based off of patient characteristics, or are you just referring for a general evaluation for left atrial appendage closure?
Well, I have to tell you that the EP guys down here, they're mostly doing Watchman at this point. We're not seeing a lot of Amulet yet, although I think it's probably going to come. When we send our patients to them for these considerations, most of the time they're making decisions on whether they're a candidate for a Watchman procedure. So we're not really getting involved in making the decision on which device they're going to implant.
Yeah, I would agree with that here in Columbus as well, that when we have such a robust structural multidisciplinary program that we usually would defer to them. And we just have a little bit of experience with Amulet, which has been very positive so far. Ben, how about in Cleveland, on the services you've been working on? Do you feel like it's pretty much left to the structural team to decide how to proceed with a specific device or approach?
As the cardiology fellow, we'll admit some of these patients beforehand with a GI bleed, and that's how their candidacy is revealed. And for the most part, all of the referrals, the electrophysiology team is selecting the device type. I wanted to also pose this to Andrea. As a fellow, we will see the patient beforehand and we'll do the TEE after placement at the intervals. But we just want to know from your experience, because you interface with the patients afterwards, we always hear about the bleeding that is subsided after coming off anticoagulation, but can you speak a little bit from the patient perspective, from what they're telling you about, what life is like now coming off of anticoagulation?
Yeah, it's all over the spectrum. I think now, with previously we're only implanting in patients that were very high risk of bleeding. And so those patients were in and out of the hospital or in and out of the endoscopy suite trying to get temporized in order to even allow short-term anticoagulation for the procedure. So, those patients inherently had better quality of life, less anxiety. But even for the other patients that maybe it was a little bit of a softer indication of they're using a wheelchair, they're using a cane and a walker, and they've had a couple of, falls or near misses. And for them, it was more of that prevention, and it's just taking away a little bit of the anxiety of worrying about a major fall, especially as we look at some of the newer clinical trials, such as with Option and Champion. We're going to be implanting these in healthier patients if those trials are positive. And so it's not just going to be people having that major significant lifestyle improvement with lack of bleeding, but just kind of opening up the ability to kind of do the things they want to do and not be so concerned about things.
Well, thanks, Andrea. I think that was a excellent summary of a very detailed presentation that I think is a topic we're going to continue to hear a lot about. So Ben, I know you helped put together this very interesting session on the top trials of 2021. Can you just fill us in on how you and the other fellows went through that process? That was Alex Miller and Farhan Nasser who joined you in that presentation.
Yeah, so first, I just want to say it was a great experience for fellows in training to be a part of the trial review. Alex, Farhan, and myself, we had to work as a team to kind of pick the top 5 trials that we thought represented the different disciplines in cardiology in 2021. And we left some off. Obviously, it's difficult to narrow it down. But we started by just identifying which discipline we wanted to cover. So first, I'll just describe the 5 that we picked with a clinical summary, a one-liner of how it applies to our relevant sort of clinical practice. So first was the LOOP trial. And, this was a study about AFib and really surveying patients before a clinical event. And clinically, we thought this was relevant because the consideration of preemptive AF management and should we implant loop recorders in patients to catch AFib ahead of an event. This trial really was a large trial that showed that there was no difference in clinical outcomes. So we thought this was important because regardless if you're an electrophysiologist or a general clinician, it pertains to your patient who's asking, should we actually monitor me for atrial fibrillation to reduce stroke risk? And we found out that through this trial, there's no difference. The second trial that we went over was in the structural heart realm, and that was the AVATAR trial. As TAVR becomes more of an option, the question of in asymptomatic patients with severe aortic stenosis, should we intervene before clinical symptoms manifest? Is there any benefit to that? This study tried to assess that. And overall, the study was basically asymptomatic patients who had to have an exercise treadmill stress test and had to be negative in terms of they had no exercise limitation for their age and gender. Do these patients do better or worse with upfront aortic valve stenosis? And this was surgical aortic valve stenosis. So they found that there was a difference in heart failure hospitalization in those patients who got preemptive surgery, in that they didn't wait for symptoms. But this was a small trial that was done mainly at one center in Eastern Europe. But I think the reason why we picked this one was as TAVR becomes more of an option, your patient who is 70 years old who has severe AS and doesn't have symptoms, would you then offer TAVR because that's less of a surgical risk, obviously, than SAVR? And this is a compelling study that hopefully sheds light on that in the structural heart realm.
Thanks, Ben. Regarding your first study, the LOOP study, I thought that was a very, very interesting study because, I'm sure the other clinicians would agree the use of implantable loop recorders has kind of exploded in recent years. And it's always been a question of a lot of clinical cardiologists, what is the clinical relevance of incidentally detected atrial fibrillation? Andrea, do you think a study like that might change how we use ILRs? Or do you think there's just more to learn about, the clinical implications of any arrhythmia you might detect?
Yeah, I think it's still pretty controversial, especially in electrophysiology where, we're not necessarily implanting them for diagnosis. We implant a lot post-procedurally after ablation to follow their burdens. And even that, I think has changed in the way we think about things. We used to think about ablation failure as if there's 30 seconds of atrial fibrillation. Now we consider it actually ablation success as if you can decrease their burden over time. And I think that, loops still provide a lot of value in the ability to do that. There's definitely still a great role for monitoring for cryptogenic stroke. But, I thought this was a nice study. I'm glad that it was presented, even though it wasn't a positive study. But, I do still think that there's a very good role for these long-term cardiac monitors.
And Andrea, you brought up a great point. That was a question we had, was the authors used 6 minutes as a cutoff for atrial fibrillation. And I think this is thought-provoking, is how much AFib is too much or too less. And the authors use 6 minutes, but I know that's been a point of discussion.
Yeah, definitely. It's still a controversial topic of exactly how much. If you take 6 minutes versus 6 hours versus 24 hours, and you dichotomize that against their actual CHA2DS2-VASc score, you do see this relationship that even when patients have very low burden of AFib, but very high CHA2DS2-VASc score, there is still stroke risk there. On the other hand, if you take very low CHA2DS2-VASc score and high AF burden, it's that inverse relationship. So I don't know if it's ever going to be as simple as picking a perfect time and basing anticoagulation recommendations off of that. I think it's a little bit more of a complex analysis.
So Ben, what other studies did you want to highlight?
Yeah, so for our third one, we went over the MASTER-DAPT trial, and this was a multi-center randomized controlled trial that was a non-inferiority trial, basically trying to answer the question in high-risk patients who are high bleeding risk and high ischemic risk after a percutaneous coronary intervention, does 1 month of dual antiplatelet therapy, is it non-inferior to 6 months? Now, this trial has a bunch of limitations. They used specific type of second generation drug-eluting stents, but they found that it was in fact non-inferior. And I think the real way that this applies to not only interventionalists and cardiologists, but also internists as well, and providers who interface with patients who have had interventions, is when can we safely take patients off a dual antiplatelet therapy after an intervention?
Joe, you're very close to this in your practice there. Have you seen a trend towards more specialized DAPT recommendations? I know this could be an entire podcast in itself.
Ken, this topic is quite variable depending on the interventionalist, and probably similar to what's going on with you guys in Columbus. If there is a special circumstance that comes up with a patient, then sometimes we'll have a dialogue before we do the intervention and talk about, DAPT, how long, how much, what drugs, and we'll work something out. Most of the time, the interventionalist, particularly if it's a complex PCI, they want DAPT longer than I would necessarily want to have it. So there's just quite a bit of variability. I will tell you, though, that with the population of patients that we have, the age, the comorbidities, I see a lot of antiplatelet related complications, hemorrhage. And of course, with the overlay of the atrial fibrillation epidemic, it's even more an important issue. So I'm a fan of de-escalating DAPT as soon as possible. I think.
Yeah, I agree that at least it's nice when you have a clinical need to de-escalate, that now there's more data to help support the decision. So it's great to have more studies like this to help clarify that. What else do you have, Ben?
Yeah, so for our last two, we wanted different settings. One trial that addressed the global need, and one that kind of addressed HFpEF, because that's a new sexy topic. So first, for the global need, we went over the SSASS trial, so salt substitute and stroke study. We thought this was a really remarkable trial that was conducted in 5 provinces in China, where they clustered randomized patients or participants, and they gave for the intervention potassium chloride instead of sodium chloride. So basically a salt shaker with potassium chloride was given to every family. And what the clinical question was the salt reduction, the sodium chloride reduction in the diet lead to a hard outcome reduction of stroke? And they did this over 5 years, and it was a very eloquent study. And the primary outcome, which was just stroke, so it wasn't a composite outcome, stroke was statistically significantly reduced just by doing this low cost intervention. So I think it's really important, especially on a global scale, but it can be applied to, we'll just say, the United States, because a lot of our issues are hypertension related, stroke, heart disease. And as we're dealing with new pharmaceuticals that cost a lot of money, this is a very low cost intervention that I think can be applied to our patients right away.
Yeah, well, I think that's a very well done and relevant study that hopefully will have an impact on our preventive practice.
Yeah, the last study that we went over was probably the most famous of the year, was Emperor Preserved. And so, that was based on the backs of SGLT2 inhibition in HFrEF, in diabetes and renal disease, and all these significant outcomes. And obviously, as we know now, Emperor Preserved was in the heart failure with preserved ejection fraction population with a EF greater than 40%. And they randomized 1-to-1 using empagliflozin. And their primary outcome was heart failure, hospitalization, and CV death, this composite endpoint. And it was statistically significant. Now, of course, in these composite endpoints, it's usually heterogeneous driven. And in this case, it was driven more by heart failure hospitalizations. But the bigger thing, and you can nitpick the trial a little bit, but the bigger thing was in this population of HFpEF patients, this is, one of the first drugs we have that really moves the needle in terms of hard endpoints. I wanted to know, clinically now in practice, are you prescribing these with your heart failure with preserved ejection fraction?
I will tell you that this is a step in the right direction for HFpEF from as far as we can tell. I personally, and I think most of the heart failure team, I can't speak for them all individually, but we're a little underwhelmed with the study. I think if you have a HFpEF patient and they are having recurrent hospitalizations, it might be reasonable to give that a try to see if you can help with the hospitalization burden. But, without cardiac mortality benefit or something else that gives you a good reason to use. A lot of times these people are on, 5, 6 medications for everything else that's going wrong. And it's kind of hard to sell them on this unless they're a diabetic, in which case sometimes you can get it in that way.
Yeah, I agree. I agree completely, Joe. I think it's a great first of hopefully what will be a lot of upcoming literature to help clarify who benefits. I would also refer everyone to our second podcast in which Dr. Castle outlined in a lot more detail the details of that study, as well as some of the limitations in that overall presentation, along with Dr. Ken Varian from Akron on the contemporary managed heart failure. So I would definitely refer anyone with an interest in fine-tuning their heart failure management to refer back to that episode. Well, thanks, Ben. I think that's a tremendous amount of work you and the others did to bring those forward and summarize them like that. So we appreciate your efforts.
It was a great opportunity. Thanks for the call.
So our final topic, just for the last 10 minutes, will be the Wiggers lecture itself. Joe, I know you were involved in the selection of Dr. Maurer to be the Wiggers lecture, which is quite an honor. Dr. Maurer, of course, is on faculty at Columbia. He's an expert in cardiac amyloidosis. And I thought he just gave a very, very detailed, but also clinically relevant presentation, not just about therapy and diagnosis, but also about some of the clinical aspects. What did you think were some of the key take-home points from his presentation?
Yeah, Matt Maurer really is sort of a laid-back, self-effacing, incredible expert in the field of amyloidosis. I mean, Matt and his group have contributed tremendous amounts to the field. And don't forget, we had Maz Hanna, who is, equally a maven in the field of cardiac amyloid. And he's really retooled all of us, at least in this area, on the correct way to approach this and how to really work up and treat this disease. Matt went through all of the major important features of amyloidosis, both AL and TTR. And not only did he talk about the clinical stuff that's important, and I'm going to kind of mention here in a minute, but, he sort of gave you a little insight into all the new stuff that's coming as well. And this is a field that's changed rapidly over the last 5 to 10 years. And I think you're going to see even more tremendous advancement in this over the next 5 to 10 years. So some of the highlights of Matt's talk, first, he started with, I think something that we all need to keep in the back of our minds is that amyloid is considered a rare disease, but it's probably not rare by clinician definitions. And it's still relatively underdiagnosed and undertreated. And that these patients really do best the earlier you get them into treatment. And that is particularly true of AL amyloid. And I always tell the fellows the best reason to look for TTR amyloid is to find AL amyloid, because those patients are really a medical emergency and need to get into the system as soon as possible. And it's clear that amyloid doesn't really have any, to the average practitioner, any hallmarking features that would, light up your brain to say this person's clearly got amyloid. I mean, the end stage elderly white guy with, a heart that's super thick and monstrous atria and heart failure and no voltage on his ECG, that's not going to be hard for anyone to pick up. But that's not the person, that you want to get into your practice. I mean, obviously you want to make that diagnosis for that patient, but you want to get them long before they get to that stage. And I think that's what some of the nuances are that help us get there. And Matt kind of went over them using things like, your clinical suspicion in patients who have heart failure and aren't doing well on heart failure medications. We know that these patients have a restrictive cardiomyopathy, and he very eloquently went over a lot of the science behind that, looking at pressure volume curves and why these people wouldn't tolerate the medication we use for standard HFpEF, or even these patients have, low stroke volumes. They use their heart rate to help compensate for their cardiac output. So they don't do well with beta blockers. They don't do well with afterload reduction therapy. They oftentimes will have a narrow pulse pressure and the blood pressures will be on the low side. He also talked a lot about some of the touch points where we may get suspicious that a patient has amyloidosis. And from the history, it's the heart failure, it's the low flow, low gradient AS patient, particularly with a preserved ejection fraction. It might be someone who has atrial fibrillation and a slow ventricular response on no AV nodal blocking drugs. It may be patients who have a need for a pacemaker or heart block of other forms with no good reason. So these are all potential red flags, we call them, for the presence of amyloidosis. The orthopedic manifestations that Dr. Hanna has written about extensively are important, and we should be using them in our history to uncover some clues to the presence of amyloid, and certainly carpal tunnel syndrome, lumbar canal stenosis. And Matt showed a picture of a patient with a biceps tendon rupture, and if they have a thick heart, that person likely has amyloid without having to do too much more. He highlighted some of the workup for this. He talked a little bit about the echo and some of the prototypical findings on echocardiography, most commonly things like a thick heart and big atria, but other more subtle clues that are really important, such as intraatrial septal thickening or thickening in the valve leaflets for no good reason, and in particular, RV wall thickening. That's another clinical clue, particularly in a patient who doesn't have a reason to have that, no pulmonary hypertension or pulmonary issues. And then he talked a little bit about the electrocardiogram and its insensitivity if you're waiting around for low voltage. In his paper from Columbia, only about a third of the patients that had amyloid had the clinical criteria for low voltage. So we want to try to use low voltage and maybe an index of a myocardial med that may help us. The other things that he talked about, which are really important, are when you finally decide to work someone up for amyloid, it's very important that you are working them up for AL amyloid and TTR amyloid. Now, there are other forms of amyloidosis that are out there, and the larger you're centering, the more people you see with this, like here in Akron, we have a smattering of other non-AL or TTR amyloid patients, but the majority of what the clinicians are going to see in practice in this country is going to be TTR amyloid, either the genetic form or the wild type, and AL amyloid. And when you're working a person up for amyloid, you really need a thorough workup for AL. There's a lot of papers and reports in the literature of people getting TTR workups and being treated for TTR amyloid. And in fact, they have AL amyloid because some of the things we do to work up TTR, AL can look similar. So it's very important that you make sure you do your free light chain assay. He focused a lot on using technetium pyrophosphate as a radionuclide. This has really been a boon to, as you know, most of the patients required endomyocardial biopsies for TTR amyloid in the past, and this has helped to save some people from having to go through that. And if you remember some of the earlier papers that were published and Matt and Maz Hanna had been involved with, these were people who clearly had, high likelihood of having amyloid. And when they did the pyrophosphate scans, they were the ones that were positive really predicted very well that this was going to be amyloid and didn't require a biopsy. Well, we're doing many more pyrophosphate scans on people with just a little bit less of a pretest probability of having the disease. So some of these scans are coming back either equivocal or positive, and the patients don't have amyloid. And that's a big issue because to put them in treatment, which is extremely expensive, you really want to be absolutely sure of the diagnosis. So he reminded us to make sure that when we do these nuclear studies, and Kenny, I know you do these, to make sure you're not looking just at the blood pool imaging, but you're looking at the SPECT imaging as well. And that's a very important part of making sure that abnormalities are in the tissue, the myocardium, and not the blood pool. The other thing about this is I think any clinician who orders one of these studies probably needs to look at them themselves. We've had a couple instances where our studies were read as negative and they were indeed positive, and vice versa. So he really is, he's done a lot of work in bringing pyrophosphate scanning to the forefront. And then lastly, he did a whirlwind and wonderful focused presentation on the therapies for amyloid, both AL and TTR. And I thought that was really quite phenomenal. We talked about where we are today, the state of the art, but importantly, where we're going to be in the next several years. There's a lot of new agents coming out for TTR amyloid in particular, including gene silencing agents such as patisiran and some anti-amyloid drugs, as well as other stabilizing agents like AG10. So he did a weekend's worth of a review on a topic in less than an hour. It was really quite phenomenal.
Yeah, I agree. It was an excellent review. And as an imager myself, I think we've definitely seen a learning curve with the PYP scans over the last couple of years as us imagers have become more comfortable with the reading. And I think that has cut down on the false positive diagnoses now that we know to look at the SPECT images and not just rely on the ratio alone. So I've also seen an interesting role for serial PYPs. Sometimes you have an equivocal reading, and I've seen the hematologist order those again after 6 or 12 months, and sometimes that clarifies things as well. I know we're up against our time, so I just wanted to thank all three of you again for not just helping plan and put on the Spring Summit a few weeks ago, but also for joining us tonight for the recap, which I think will be very helpful to our practitioners, some of which didn't get to see those sessions. I want to remind the listeners that all of these sessions we're referring to are actually available at ohioacc.org, which is our State of Ohio website. There's actually links to the videos for all these presentations. So Andrea, Ben, Joe, thank you again for joining us.
Appreciate it. Thanks.
Thank you for joining today's podcast. For more information about the speakers or the topics, please go to ohioacc.org.